Good evening, everyone.
Recording in progress.
On behalf of the Indian Academy of Otolaryngology and Head and Neck Surgery, uh, I welcome you to this GSK IAOHNS webinar series 8 on contemporary ENT practice. This month, we have chosen the interesting topic of maxillofacial disorders, a multidisciplinary approach. We have got a galaxy of speakers, and to lead from the front, we have Dr. Rahul Modi from Mumbai. I welcome all the speakers, Dr. Modi, Dr. Dipankar Datta, Dr. Mihisa, Dr. Manikandan will be joining us very soon, and Dr. Roshan Ryan. I hand over the microphone to Dr. Vijay for the Secretary of IAOHNS to introduce the speakers. Thank you very much.
Thank you, sir. It's my great pleasure to introduce my dear friend, Dr. Rahul Modi, to moderate this entire session and to give the intro talk and to take it forward. He's an ENT surgeon, basically, and he's very much interested in head and neck oncology, and he did his fellowship, and he's also practicing mainly sleep apnea surgeries, and that's how we all became close to each other. So currently he is a consultant at Dr. LH Hiranandani Hospital, Mumbai. So without further wasting time, I would like to ask Dr. Rahul Modi to give a talk on COVID-associated maxillary osteomyelitis, a new entity, or how it is here. Over to Modi.
Right. Thank you, Dr. Vijay, for the kind introduction. At the outset, I would like to thank the Indian Academy for this opportunity. It's been a pleasure being part of the Academy and participating in this webinar series. And thank you personally to Dr. Vijay for selecting this particular topic, something that as ENTs, we do come across more often than we would like to acknowledge. However, it is sometimes part of our curriculum, but still not something that we are proficient with it. So the talk that I was taking and the entity that I wanted to talk about is essentially COVID-associated maxillary osteomyelitis. And the thought of this topic is more than what it is not, and how does it different from what we have been seeing in the second wave is the epidemic of mucormycosis. And the idea is to identify that odd one out in this whole Zoom, and it is important not to miss out and perhaps overtreat certain individuals. So coming to my case summary, this was a 42-year-old non-diabetic male banker who had come to me in the clinic after a fairly, I would say, moderate to severe course. He received all the medications. He was in the ICU, was on oxygen, just shy from the ventilator, and he had literally came back. He presented with symptoms of acute sinusitis. 3 days after discharge from the COVID facility, was already started on 1 gram BD of amoxicillin and clavulanic acid, which is the standard first-line therapy for 2 days, and there was no relief. He was actually related to a radiologist. So he came to me with a CT scan and an MRI, which shows a classical bilateral maxillary sinusitis. This was literally in the peak of the second wave, where we were operating like 2 mucor cases every day. So there was a big scare amongst the family members about this patient. And however, on the CT scan, we could not find any evidence initially of any kind of a bony involvement. Even clinically, when we saw the patient, even on the MRI, there wasn't much of an extra sinus involvement, so to say. Nasal endoscopy showed a boggy mucosa all the way to the nasopharynx. Decongestion of the middle meatus also showed kind of like a normal mucosa. No frank blackness, none really to suggest it was mucor. And that is why when we did the endoscopy, rather than starting the patient on any empirical treatment, we decided to go for culture. There was a discharge coming out from the left nasal cavity, coming from the middle meatus, heading backwards. just to be slightly on the safer side. And when the discharge, the culture sensitivity of the report came in, it showed that this organism was resistant to all first-line antibiotics. It was Staphylococcus aureus. We decided to be a little aggressive in terms of starting a combination of an oral drug in consultation with the ID specialist using rifampin and a combination of rifampin and teicoplanin. However, the patient was just out of a COVID facility, didn't want it to get admitted, and frankly wasn't very toxic with his symptoms. So he just decided to, get lost to follow up, took second opinion, and met a local doctor who prescribed him linezolid, which was oral therapy. Didn't have great efficacy values, but essentially the patient was on follow for a month. Now, when the patient came back to me a month later, his symptoms, the classical acute sinusitis symptoms, had disappeared. However, again, he came to me with a fresh CT scan, which showed changes involving the bone. So if you look at the pre-op CT scan or the pre-linezolid CT scan, the bone of the palate was reasonably healthy. However, the post-linezolid CT scan and the post-linezolid MRI showed extensive bony involvement. Clinically, all the teeth in the jaw, especially the front teeth, have loosened up. The gingiva appeared edematous. So what we saw was a regular acute sinusitis had probably converted into an osteomyelitis because of probable inadequate treatment. But overall, the sinuses had cleared up compared to the ethmoids had cleared up compared to the pre-linezolid kind of initial presentation. Now, in consultation with my maxillofacial surgeon, we gave the patient a preoperative course of antibiotics like we had initially decided. We had sent a fresh culture. However, this time there was no growth because it was there was no real discharge. A combined endoscopic clearance with an open partial alveolectomy with a 6-mastectomy was done. Histopathology report shows a lot of bony destruction with extensive granulation tissue. Post-operative antibiotics was considered for about 2 weeks, and what essentially we used to guide our treatment was the CRP status. The patient persistently had high CRP in the pre-op setting, and it took 2 weeks till the CRP settled, and that is when we decided that once the local site healing was also happened, we will stop the antibiotics. I did an extensive literature search at that time, and even now, when this opportunity of the talk came in, and still now I was looking for, I didn't get any case reports of any COVID-associated non-fungal osteomyelitis. Going again deeper into the pathology, we saw a lot of granulation tissue eating up into the bone. In the high power view, you can see the scalloping of the bone tissue where the granulation tissue is actually eating up. And a special stain for fungus, that's a GMS stain, didn't show any fungal elements. Now, when we go back to the predisposing factors that we thought were responsible for the mucormycosis seen along with COVID, we saw use of steroids, early and high dose of steroids, poor glycemic control, essentially either in the pre kind of like disease setting of diabetes or the steroid-induced diabetes. Neutropenia, extended use of oxygen was proposed as one of the modalities perhaps. Use of voriconazole and use of antibiotics. So in my patient, a lot of these things were common. He was a non-diabetic. However, there was extensive use of steroids. He had neutropenia during the course, perhaps induced by COVID, perhaps induced by steroids. There was extended use of oxygen and use of antibiotics, which can perhaps explain the resistance in this patient. Now, when I look back into the case and try to compare it with other patients, mucormycosis tends to be more common in diabetic. My patient was a non-diabetic. Mucormycosis generally has a more aggressive course, whereas this case didn't have that kind of an aggressive course. It was a more indolent course. The patient took a lot of time to decide. Even after the second CT scan, it took us like, say, about a week or so to convince the patient to get admitted, and then about antibiotics, and then the intervention. Signs were kind of very distinct, with the course being much slower and presentation being less toxic. And I am guessing mine was probably not the only case that I encountered. There must be many cases across the country. There were talks amongst colleagues that they were finding it difficult to isolate fungi in a few of these osteomyelitis cases. And I'm thinking, like I said, the importance of this case, rather than what it is what it is not. It is not a COVID-associated mucormycosis. And my request to all my colleagues is to keep their eyes open for this kind of a possibility if at all they encounter such kind of a presentation in the future, especially in the post-COVID setting. So the take-home message from my side will be, not all acute presentations are fungal in origins, especially in this scenario. Keeping the communication
Rahul? Can you hear?
Yes, I can hear.
Yeah, I thought it got disconnected. Rahul? I think he got disconnected. Anyway, he has got the final take-home message. I think it was well received. Let us, he will join. Let us move to the next speaker of today's talk, Dr. Roshan Ryan. He's from Chennai. He's adjunct professor of Sri Ramchandra Institute of Health and Education Research Center, Chennai. He's a pediatric dentist and certified orthodontist, and director of Royan Dental Care Center, joint director of Kids and Teens Dental Care, and director of Indian Dental Sedation Academy, who is one of my close friend and who works, we both work together on pediatric OSA cases. And I'd like to welcome him to enlighten us about the interdisciplinary approach in pediatric dentistry, where we think your roof is our floor. Dr. Roshan?
Yeah, I'm audible. Yeah.
Yes.
Just thank you. Thank you, Dr. Vijay, for the wonderful introduction, and good evening, one and all. And thanks for this opportunity by the Indian Academy of Otorhinolaryngology and Head and Neck Surgery. That's a wonderful platform that we have given me this opportunity. And good evening on a Sunday evening. One man's roof is another man's floor, actually. So, actually, when we talk about nasomaxillary complex as such, from the anatomy, from the growth and development, it's like, it's always, they're talked together, the nasomaxillary complex. But the irony is, we have divided as two separate clinical signs, and the disorders are varied in nature. So we bump into each other in terms of problems, and that's why this interdisciplinary approach webinar has been organized. And so the roof gets blown out like this, and sometimes the floor of the maxillary sinus gets blown out, and you land up on the roof of the palate, and or sometimes it happens the roof of the sinus gets blown out and they land up in the floor of the orbit. So after the post-COVID, it's like these things are much happening, and we have to join together to reconstruct and resect whatever we need. Okay, so a lot of things have been happening post-COVID between the ENT and the dental fraternity. So a very big thanks to the organizing team and the MRF, MK sir, Dr. Vijay, and thanks to GSK for organizing such a wonderful lecture, and Dr. Rahul Mihir, everybody known to me through this webinar. And before going into the details, I'll just give you a brief outline of what I'm going to talk today. I'm just going to give you 4 common clinical scenarios where we coexist, where we need to look into whenever these kind of problems come, and how frequently are we going to see these kind of problems. So usually to keep my lectures engaging, I keep a little bit of questions and answer sessions at the end of the lecture. So probably the audiences who are looking into the lecture can answer these questions at the end of the lecture, and we'll have a take-home message for the day. So what are the 4 common clinical scenarios where we coexist? So from a pediatric perspective, I'm going to talk about OSAS, pediatric OSAS, what are the dental perspectives we need to look into and how we approach this problem from a pediatric dental perspective. Otitis media, which is recurrent in nature, which can have a little bit of middle ear infections. What are the dental perspectives you need to look into so that you can you can join together in handling these kind of issues in a much successful manner, the ENT and the dental fraternity together. Wisdom teeth and its implications to the ENT surgeon, and a small note on temporomandibular dysfunction. So these are the 4 common clinical scenarios where I'm going to talk to you today. Before going into details, sometimes what happens is the terminologies what we use are Greek and Latin to the ENT fraternity, and the same applies vice versa for us. Because the other day I was talking about some lab findings to Rahul. So Rahul was telling like, he thought it's all going to be medical lab findings, the blood investigations. But actually, what I was talking about is the dental lab findings, what I was talking about. So each of us, even we are very close to each other, the neighbors, as the roof and floor, sometimes the terminologies are Greek and Latin to each of us. So giving you a few inputs, what we say is, this is the normal overjet, what you see here, the overlap of the teeth, okay, the normal overjet. Excessive overjet is the teeth are placed much more forward. So that's the what you call as the horizontal relationship between the teeth, where the upper teeth are very forward. So this is a very common scenario you will see in from an ENT perspective, a class 2 occlusion, what we call. So in pediatric OSAS patients, and a convex profile. Okay, so excessive overjet. The overjet, what we call, is a horizontal overlap. So here the teeth are more placed forward. This is called vertical overlap. So normally the vertical overlap is only minimum, and you see the lower teeth very much visible. If it's a deep bite, the lower teeth is not completely visible. So this is a common scenario you see in patients with, from an ENT perspective, you need to see this problem. This deep bite is more commonly seen in patients with otitis media, recurrent otitis media, because of which the mandibular condyle is placed more posterior, because of which there is a block in the eustachian tube flow, and which can land up with the recurrent effusion in RME cases, recurrent otitis media cases. So here, actually, normally you see the upper teeth are overlapping the lower teeth like this, it has to overlap. So here in this case, it's reverse overlap. This is called anterior crossbite. Actually, the reason is the maxilla is little narrow. Okay, so narrow maxilla is also a very common finding in OSAS patients. So this is called posterior crossbite. This is also very commonly seen in narrow maxillary conditions. And in these kind of situations, you will need to look for expansion. So the second picture, what you're seeing. So a few pictures to see and identify. These are not normal conditions. These are abnormal conditions. Hidden posterior crossbite, what we call. Normally, the upper teeth have to overlap the lower teeth in every situation. Here on the back side, the lower teeth are overlapping the upper teeth. They are placed outside. That means this indicates the maxilla is narrow. So this is also another same clinical situation. So this is how it will look in the real scenario in a patient's mouth. So these are 3 profiles we categorize: a straight profile, a convex profile, and a concave profile. Straight profile is a very balanced profile, is a very good profile. Convex profile is not a good profile. And this is a very convex profile is always seen in patients with OSA. And what you see is another is a concave profile. This is also rarely seen in OSA patients. So these are lateral cephalometric radiographs which we use for assessment of airway. So this is the tool which we use for assessment of airway. And the other investigative tools what we use are photographs, the lateral ceph, RPG, and study models. These are study models we take and we do some dimensions to assess, study the process of the teeth positions and the dimensions. We call it 4 T's are bad from a holistic dental and ENT perspective. The 4 T's are nothing but lip tie, tongue posture, tongue tie, and tongue swallow pattern. All 4 T's are considered bad words and bad for the holistic development of the dental and the ENT from a muscle functional developmental perspective. I repeat, muscle functional developmental perspective. So the common sleep apnea findings we see are, you see a tongue thrust, the tongue swallow pattern is not right. Either you can have a narrow maxilla, this is the first clinical condition I'm going to talk to you. You have a posterior crossbite, you can have a protruded upper front teeth, that's the excessive overjet, or a short mandible, and a convex facial profile. These are the common findings. The mnemonic what we use is a TNPPSC. Tongue thrust, narrow maxilla, posterior crossbite, protruded upper front teeth, excessive, because right now, whatever the basic terminologies I've been using, I'm putting it to use right now. So a short mandible and a convex facial profile. Sometimes you have underdeveloped maxilla or a reverse overjet or a concave profile in a few cases of OSAs also. So the prevalence is very, very high. 1 in 4 to 5 patients, what we see in a routine pediatric dental practice, we are able to see with a rise in the sedentary lifestyle. So how do we approach it? There are two ways we approach it. The generic term, what we coin it as malocclusion. So malocclusion, if it is purely a functional malocclusion because of a purely an OSA, you need to start intervening as early as possible by 6 years. Sometimes there is a combination. There is a combination of a genetic pattern along with a functional issue. In these kind of situations, whatever the functional corrections you are going to do, if there is a genetic growth pattern of a type of malocclusion, the same will remain as the growth is going to happen. The same will keep expressing. So this you will be able to identify with a good case history and a clinical diagnosis and a proper history with the parent. If your parent is having a similar facial profile, then it is going to be of no use intervening at an early point. So we need to start intervention little early, but keep them monitored over a period of time. And it's a 10-year program from 6 to 16 years. So routine OSAs, you just take an ENT evaluation, get the tonsils or adenoids removed if needed, or else on medications. And if the jaw positions are right, and if there is a characteristic adenoid faces with just mouth breathing, we just rule out the habitual component of the mouth breathing. So this is a characteristic adenoid faces, a convex profile, incompetent lips, open bite, what we have. So in these kind of situations, a routine oral screen, which is a removable appliance, which we will give to correct the habitual component of mouth breathing. There are some more better components which are available, like a myo brace, which is a thermoplastic silicone material, or we can try chin straps and all those things. Coming to the narrow maxilla with posterior crossbite, which is more vigorously seen in certain pediatric OSAS cases, we need to look at the cause and effect, whether there is enlarged tonsils, adenoids, whether there are any habits, thumb sucking or mouth breathing, whether there is any snoring at night, prolonged breastfeeding or bottle feeding, which has caused this issue. So a proper case history evaluation from a myofunctional developmental perspective, we need to look into. Speech difficulty, if it is any, is there. Look for evidence of cheek bite, excessive daytime sleepiness, history of cleft palate surgery, and nocturnal enuresis. This is a very common seen in OSAS patients, especially with narrow maxilla. So a lot of evidence-based discussions have happened, and which have told that narrow maxilla, when you start expanding, you get to improve the nasal breathing, the nasal airway resistance is reduced, the flow is improved, everything. So there are a lot of articles to consider OSAS. RPE is one of the, RPE what is short form called rapid palatal expansion, or RME what we call as rapid maxillary expansion. These are again web articles to show you that the obstructions get cleared out when you do the expansion. And Mr. Kural is a person who's been the pioneer, who has done a lot of work on orthodontic maxillary expansion, etc. And RPE also controls nocturnal enuresis when all other treatment modalities have failed. This has also been reported. So coming to the evidence-based summary, there is sufficient evidence to state that dental malocclusion, upper airway obstruction, and pediatric nocturnal enuresis are a coexisting family of factors leading to OSAs. How do we go ahead treating this problem from a dental perspective? First, take an ENT evaluation, look out for any upper airway obstruction, clear it out, or start on any medications. If there is surgery involved, go for the adenoid tonsillectomy, and then plan for the work what we need to plan from the dental perspective. Second is to have a urologist opinion for a PNE to rule out any uropathological pathology in place. So these are some maxillary expanders. These are slow expanders, what I'm showing you. This does only dental expansion, but this is my Go appliance. This is called the Maxillary Rapid Palatal Expansion appliance, which is called a Hyrax. This is my appliance of choice, when it comes to skeletal expansion and dental expansion together, what we want to achieve. And this is how this appliance looks like. And there is something called as has expander. This also is a very good second choice of appliance, which we regularly use it in our clinical practice. So how this appliance works, this is a small video, how it works, how the crossbite gets corrected. There is a keyhole in this appliance, which has to be activated with a small key kind of thing. And this is like a cartwheel with 3 holes. And every day we do 1 turn of activation. This is like a distraction osteogenesis. So this automatically gives you about 0.25 mm of expansion. So 0.25 mm of expansion happens over a period of time, which is calculated based on, we do a calculation with a model. So how much of expansion is required, how many turns have to be done, everything which has been done. And this is the before and after the expansion is happening. Pictures of patients who have undergone maxillary expansion. What exactly happens? So we are looking at 0.25 mm, 2 mm of expansion or 4 mm of expansion. So what exactly happens? Nasal, we are at the bony level and the sinus is considered like a cavity. So when we do some maxillary expansion, suppose we are doing about 4 mm of expansion, the sinus, if it's considered like an air cavity, so we are looking at a cylinder which is getting expanded. So length into breadth into height. The formula of a cylinder is length into breadth into height. So we are kind of looking at 4 into 4 into 4. That's about 64% increase in the volume of air which is the child is being taking. From that, there is an increase of 64% from the existing air volume what the child has been taking. So that is what we are going to achieve with just about 4 mm of expansion. So the airway space, you see, this is a case I'm just showing you. The airway space, the arrow mark which has been there. After the expansion, how much of airway space is increased? In this case, we are expanding the maxilla. At the same time, we are bringing this mandible forward also. I'll be showing the appliance what I've been using. So we brought about forward placement of the mandible also about 4 mm, and we could gain this much amount of increase in the airway space. So looking at the airway space, you can just see that the difference in the achievement. So this is the appliance what we used. It's a fixed twin block with Hyrax. The same upper maxilla is also expanded. At the same time, the mandible is also brought forward. And a little bit of alignment correction with this 2x4 appliance has also been done. And this is the pre and the post of the child who has undergone this expansion and bringing the mandible forward. And this is the results what you are seeing here is the results of the expansion. The child had extreme gag reflex. So that's why the upper jaw photo and the pre-op photo we couldn't take very easily. We were very much finding difficulty with managing this child. So, and after the expansion started happening, the tongue started settling in place. Child became very cooperative, and we were able to take good photographs after the expansion was happened, because the hypersensitive gag reflex all reduced, tongue position settled down much more better. So that was how. And this is the pre and the post profile change what you see here. And this is a smile line. This is a 9.5-year-old boy who has done this work. So here is another case where we have done some, you can see the child's head little stoop forward. The cervical spine position is little forward, the head is little forward. But after the expansion, the cervical spine position is much more better. So this is again a fixed twin block with Hyrax. Hygienic rapid palatal expansion has been done. And these are the results what we see after the expansion has happened. These are some common anti-snoring devices which we also incorporate based on a subjective case-to-case basis. And mandibular anterior repositioners, chin cap, and a reversible headgear if the maxilla is actually narrow or which is underdeveloped. Coming to the recurrent otitis media, where we see fluid collection, I'm not going to details about the pathophysiology because you people are the masters in it. So I'm not going to details about that. But the classical dental findings, what you see is a deep bite, a narrow maxilla, and a typical class 2 malocclusion, which is a convex profile. So in these kind of situations, it is always what they say is in the tensor veli palatae and the TVP and the LVP, levator veli palatini muscles are a little relaxed. So we want to stretch dilate the muscles. For this, when you do a rapid palatal expansion, this is a very good tool to improve when the transverse maxillary expansion happens. it settles down the eustachian tube blockage, the patency is improved, and because these muscles also get a little stretched up. Okay, so this is considered as a very good alternative tool for RME. RME is an alternative tool for otitis media with effusion. So this is the evidence-based article which has been, I'm sharing it with you. RME actually stretches the TVP and LVP, thereby enhancing the patency of the eustachian tube. Wisdom teeth and its implications to an ENT surgeon. Many a times in the morning at 10 o'clock or 10:30, I get a call from Merv saying that there is a patient walking into you for rule out any dental problem. They are complaining of earache, severe earache, but we don't see any ear pathology there. So when we look at it, it's commonly a wisdom tooth which is impacted. Actually, wisdom tooth, when it gets impacted, it impinges on the inferior alveolar nerve, which is a branch of the mandibular nerve, and always auriculotemporal nerve is also part of the mandibular nerve. So it always looks like a earache most of the time. So, or a migraine type of pain. So, but there is no ENT pathology there. So many patients who have no ENT pathology, but typically having a radiating pain to the ear, it is always necessary to have a rule out the dental perspective of some kind of pathology in the mouth, in the oral cavity. So these are common situations where wisdom tooth impacted, getting treated for landing up to the ENT people, and then getting referred back to us to get these kind of problems sorted out. So again, this is another common clinical scenario where there is a patient lands up to our ENT fraternity and complaining of earache, and actually there is a temporomandibular dysfunction which has happened because the joint is a little mismatched development, or it could be a strain in the temporomandibular joint due to kind of a stress induced, or if there is any other dental pathology. There is a very common scenario seen. It's called temporomandibular dysfunction. Sometimes a combined modality of a deprogrammer, which will just relax the lateral pterygoid muscles and the other circum muscles attached to the temporomandibular joint, eases the complete issue of the temporomandibular joint dysfunction, along with a few skeletal muscle relaxants, which will help them out. These kind of patients. So these are 4 common clinical conditions where we coexist with each other, where we need to work together to get things for the benefit of the patient. So the master listener game for the day is the ideal age to start intervening dental issues for the functional OSAS. So people who are there, the audience there, you can try to answer this. The appliance of choice to correct narrow maxilla and posterior crossbite. Mnemonic for the dental findings of OSAS. And 4 T's. What are the 4 T's which are considered bad for development from the myofunctional ENT and the developmental perspective? So these are the 4 questions. And the finishing quote for the day. OSA. We don't like OSA. We avoid it. But OSA likes us. We can't avoid. So, trying to, on a lighter note, I'm just saying this. So, this is, mark my words, this is going to be a real, the prevalence is very high. So, next 5 years, many patients we are going to encounter, and we need to co-work together to get this sorted out for the benefit of the patient. Thanks for this opportunity. Thank you all. Thank you.
Thank you, Roshan. Nicely, you have brought up many points to discuss. I think Dr. Rahul Modi will cover it up when we have a panel discussion. There are a few questions like Dr. Ahalya from Bhimavaram, Andhra Pradesh says lasers in pediatric dentistry.
Okay.
So what's the role of laser in pediatric dentistry?
Yeah, we do some soft tissue surgeries like lip tie, tongue tie, all those things we are doing. Diode lasers are being used for that. And apart from that, laser we for general small soft tissue surgeries we are using, but no hard tissue cutting. We don't use lasers. For small soft tissue procedures we do.
So there are many other questions. Most of the questions you have already answered during your discussion. So let's move on to the next speaker, Dr. Manikandan, who is a close friend of us, who is a professor and director, Meenakshi Cleft and Craniofacial Surgery, Meenakshi Ammal Dental College and Hospital, Chennai. So I would like to welcome him to give a talk on osteomyelitis and its implication in maxilla and sinus pathology. Over to you, Dr. Manikandan.
Thank you all for being here and Sunday evening. And so what I have been asked to speak about is osteomyelitis. That the voice is clear?
Yes, sir.
Hello?
Voice is clear. Yes, seen, heard very well, sir. Seen and heard very well.
Thank you. So in my last 32 years of practice, I have to be very frank with you that most 98% of the cases of osteomyelitis, what I have seen in my practice is more in the mandible. Very, very rarely we saw the maxillary osteomyelitis in our clinical practice because of certain reasons. I'll come into that. Only during this COVID period, we saw so much of fungal osteomyelitis. Other than that, 90% of the cases what we see osteomyelitis is in the mandible. Okay, now let me come into that. Why in maxillofacial surgery, the mandible is more commonly involved with the osteomyelitis? Because osteomyelitis of the maxilla is a rare event because there are there is a lot of antibiotic now we use it. Number two, that there is a lot of blood supply to the maxilla in comparison to the mandible. This particular picture will show you how good the maxillary blood supply is in comparison to the mandible, where the mandible is purely relying on the endosteal and parosteal blood supply. It is like a tubular bone. It is like a tubular bone where there is a mandible is very easy to undergo osteomyelitis in comparison to the maxilla, which was totally different during the COVID period, where there was a lot of involvement of mucormycosis and the maxilla, the moid and orbit, zygoma, everything went disarray. So it is really surprising. There is a lot of pathology, which all of you know that what happened, during that time. And we will probably discuss that in the next session of this thing. But as far as I'm concerned, in the last 30 years of my clinical practice, I can say 90 to 95% of the osteomyelitis happened in the mandible than maxilla. Okay. What type of osteomyelitis? What we saw in the maxilla area associated with sinus is more of a suppurative osteomyelitis. 99% of the cases of osteomyelitis in the maxilla were suppurative. Pus, abscess, fistula, sequestration, and there is some amount of pathogen always present. Only in the mandible we saw non-suppurative chronic osteomyelitis more than maxilla. Maxilla I hardly saw non-suppurative one, hardly I saw. When it comes to the etiology part of it, why do you get, we found that maximum number of problems happen because of bacterial focus, maximum number. Normal, I'm talking about in the last, if I take about 200 cases in the last 30 years, let us say, 190 happened because of bacterial, or 170 or 180. Only in the COVID period, we saw 99% happening because of fungal infection. And also sometimes bisphonates and radiation-induced problems also happened like that. Just now, we were speaking about the role of teeth in developing osteomyelitis. Periapical infection. That means infection happening at the level of the at the apex of the teeth. It can affect the type of pathology there. It can easily affect the bone at the apex of the teeth, and the lining get disturbed. And because of this lining, it will eventually lead into what is called as rhinosinusitis or sinusitis, which will lead into rhinosinusitis. And thereby, a chronic rhinosinusitis can lead into, if not treated properly, into osteomyelitis. So that is the most commonest problem one can expect from the teeth when it is origin from the odontogenic infection. So when I say odontogenic infection, from the teeth as it is. Okay, right. Let us say what type of organism which we have seen in the last 20, 30 years is that even today, if you see, Staphylococcus aureus are the maximum number of infection which has been seen, and also other Staphylococcus, aerobic ones, and pneumococci, Escherichia coli, Bacteroid, all these things which are seen here, all these are, which is very, very commonly seen in the adults. And in a pediatric group, and sorry, before that, into that, I just wanted to say that the maxillary sinus osteomyelitis involving the sinus, nose, the zygoma, orbital area, all are very common with diabetes mellitus patients. Very, very common. Before COVID, I hardly saw any patients coming just like that without, most of them were having diabetes mellitus. And also other factors which you see in the screen, there are a lot of other factors which can, lead into something which, can precipitate an osteomyelitis of the maxilla. The only other thing, what probably is that maxillary osteomyelitis is also common with trauma, also common with infection of the antrum, lacrimal sac infection, spread of infection from other sites, and so it is not only an odontogenic, that is teeth origin. Infection is not only from the teeth origin, also can be because of trauma, because of infection from other areas, and which is spreading into the entire maxilla and the zygoma and the rest of the part of the palate and everything. So it is very important to understand the pathology associated with maxilla and the sinus osteomyelitis is completely different from what normally happens with mandible. In mandible, if you take it, 90% are odontogenic, 10% of because of trauma and other things. But in the maxilla, it is totally different. The only other thing I always keep telling, we don't see that many nowadays, but in the past, when we used to be PG students, we used to see a lot of infantile osteomyelitis. Osteomyelitis occurring to the maxilla sinus of the child. Very, very common that time we saw in the government hospitals. I was wondering where we were seeing it, because then they said that it is probably because of neonatal trauma to oral tissues, hematogenous spread from skin, middle ear, mastoid, infected maternal nipple. All this can bring about it. This is just one case, which just to explain, sometimes osteomyelitis of maxilla, antrum, and other area also can occur with infantile osteopetrosis. So where the bone becomes completely, dense, no marrow, no blood supply, it's very easy to get infection in such type of children. The diagnosis wise, how do you diagnose the maxillary osteomyelitis? Is very common findings like what we see every day: pain and swelling around the maxilla, eyeball. Of course, nasal congestion, there's no doubt about it. Epiphora sometimes, nasal regurgitation of fluid because of a fistula in the oral cavity, oriental fistula. Infraorbital nerve involvement can bring about numbness of the upper lip and teeth. Intra and extraoral sinuses, fever, lymphadenopathy, history of long-term infections. All this can bring about it. This is just a clinical feature, probably what might we look into it. Having intraoral exposure of the bone, you can see there's a denuded mucosa, bare bone which is exposed, and which is very, very common with maxillary osteomyelitis. What we need to do is to take, first to start with, normally what we tend to do is that an orthopantomograph, which is an X-ray which is done to find out whether the odontogenic causes have to be ruled out. some radiographs like occlusal radiograph, MRI scans, CT scan, all this can be done. This OPG is showing how probably an infection, odontotic infection, causing maybe secondary to other etiology or like diabetes mellitus. You can see how the maxilla has become literally like a porous structure and trying to come like a siccastrum out of that maxilla. And the CT scan, of course, you can see it here as well. The CT scan also very helpful in identifying the siccastrum and other structures. So what is important at the end of the day here? What is important at the end of the day here is to get the correct imaging technique where you can distinguish the infection, where is it coming from, whether it is from directly from the nose or from the mastoid or from other areas or from the odontogenic infection. And I think we need to have a good clear-cut distinction of radiology, radiograph, CT scan and MRI to show where exactly it has come from. We saw during COVID period that CT and MRI played a big part in diagnosing and treatment mucormycosis related osteomyelitis. So in our way that any patient who comes with a osteomyelitis, the first thing is to admit the patient, take the pus for culture and sensitivity, blood test including the blood sugar. First thing is to rule out whether the patient has any diabetes. CRP is very useful to show whether there is a reliable indicators of inflammation, and which is also actually very important to find out the prognosis of the prolonged treatment with osteomyelitis. So if you ask me, how do we treat osteomyelitis related to the maxilla or mandible? All of us knows that there's no doubt about that. We start the medical management and the surgical management. Control of diabetes, protein supplement and hydration, because the patient may be having fever, inadequate intake. Underlying cause have to be identified, whether there is a chronic sinusitis or whether there is a odontogenic infection or a trauma or any implant placed in the maxilla. All these things are very, very important. And most of the time we end up in giving them long-term antibiotics. I have sometimes taken the antibiotic up to the extent of 6 weeks, up to the 80 weeks, clindamycin, augmentin, aminoglycosides. All these are actually helpful in a long-term management of this type of osteomyelitis. Surgically, if you see it, exploration, we have to explore, remove the sequestrum. We can put once it is done, removal done, you can try to close it primarily. If not, you can keep the sinus open. Second stage, you can go for a prosthesis, or if it is a small opening, you can go for a oriental fistula closure. And if necessary, a flap like an nasolabial flap and all those things. So systemic antibiotic like augmentin and other drugs, aminoglycosides, are the standard therapy. Very, very important to give for a prolonged time. And even with that, sometimes it may not help in case of a chronic osteomyelitis. That is what I have found in the last so many years. Because in osteomyelitis, there is a poor penetration of the antibiotic into the bone because of the impaired blood supply, and also associated with the problem of having enough blood supply into that area. So what is important at the end of the day is to get rid of the infection as much as possible. So what we tend to do during an osteomyelitic removal, during surgery, we remove the sequestrum, be radical, and remember, unless we see a normal bleeding bone, all other maxillofacial or other bones can be completely removed. Once we remove it, you can expect some amount of good healing even without a proper flap from other area. As I told you, so many cases of mucor with, I'm talking about not in COVID time, before that itself, I'm sure even in the field of ENT, you might have seen innumerable cases. I insist and I like to send most of this patient for a hyperbaric oxygen therapy post resection, because I found that the healing of the mucosa or the intraorally over a bone which is exposed intraorally, the healing is fantastic with 30 or 60 days of dives of hyperbaric oxygen therapy. Though there is a lot of controversies recently that, whether hyperbaric oxygen therapy is really helping. But I have found even in a COVID period post-surgically, in my private practice along with our ENT colleagues, we found together patients underwent this type of hyperbaric oxygen therapy in Chennai for at least 30 sittings of about a month or 2 months. The healing was amazing and it healed so well. We never had any trouble of going back again and trying to go back again unless there is a recurrent so much of an infection with mucor. But we hardly had 1 or 2 cases. Rest all cases healed very well. Those who can afford, we tell them hyperbaric oxygen therapy is mandatory apart from other antifungal and antibiotic, what we have seen it. So just to put that, thank you so much. Just to tell you that, yes, we had actually so much of involvement of mandible prior to this type of maxillary involvement. In my private practice, I can tell you 90% of the cases were all related to the mandible than the maxillary osteomyelitis. Maybe because that the blood supply, one thing. Number 2, that most of them were treated with an antibiotic much earlier. And we found that the osteomyelitis of the mandible can occur much more commonly because of the poor vascularity. Thank you. Thank you, Dr. Vijay.
Thank you, sir. So there are a few questions. Dr. Meenakshi Pandey from Chennai has asked how to clinically differentiate between osteomyelitis, cellulitis, and abscess, and what's the sequence of bone infection and how do they present?
Yeah. See, abscess is purely a localized phenomenon. Purely localized phenomenon. And you don't see cyclostrum in an abscess. Normally, you don't see that. You will get pus in all these cases, but normally, when you have to say osteomyelitis, you tend to have some form of bone exposure without the mucosal exposure, with mucosa denuded on the top of that bone. And that is a very classical sign, number 1. Number 2, chronicity. An abscess can occur within 2 to 3 days after an infection, but it may not happen with an osteomyelitis. Number 3 in the maxilla, very important again, that nasal congestion along with the infraorbital nerve involvement and an infection of the lacrimal sac, all these things can combine with the osteomyelitis in comparison to the abscess. So abscess, I consider it as a very local phenomenon, though can mimic an osteomyelitis features. But if we actually see it with radiograph, like mouth-eaten appearance and other areas like cyclostrum in the CT scan, it's very easy to make out. I don't think it is that difficult to distinguish between an abscess and an osteomyelitis. It's a very classical sign of cyclostrum what you get it. Mobile teeth, multiple sinuses intraorally, all these are very classic. No doubt about it.
Fine. Thank you so much. So next, move on to our most awaited panel discussion as we have pedodontists, facial plastic, facial maxillary, ENT, pedodontists, everyone together. So we can have a nice panel. I would expect Dr. Rahul Modi to moderate this session, managing maxillofacial disorders, a multidisciplinary approach. Rahul, over to you.
Thank you, Dr. Vijay, and my apologies for the interruption in the previous talk. My connection, as you can say, just died out. So So going forward to the panel, I'm actually looking forward to the inputs. Excellent talks there by Dr. Roshan and Dr. Manikandan sir. Lots of important points being made there. Now, talking about the panel, when I was discussing with Dr. Vijay, we decided to stay away from the more common things that we interact almost on a regular basis. So we stayed away from malignancies, we stayed away from maxillofacial trauma, and the mucormycosis wave too. I actually took up a case which is essentially will suit to the panel, and the first case being a rare presentation, and the second case being that of or not so rare presentation. Let me put it that way. So we have eminent panelists with us. We have our very dear own Dr. Dipankar Datta, ENT surgeon par excellence, one of the founder members and the committee members of the Indian Academy for Surgery for Sleep Apnea, ISA, and also a very active propagator of sleep medicine, I would say, in the country, educator for a lot of ENT surgeons. I think Dr. Jayant is yet to join. Dr. Vijay, I don't see him. He was supposed to join us. Yeah, from Erode. A person with a lot of interest. We have all listened to Dr. Manikandan sir from Chennai. We have Dr. Mihir Shah. He is a pediatric dentist and practices in Mumbai. Has a keen interest in the field of sleep disordered breathing in children and does a lot of work in that aspect. And I have learned a lot of my pediatric dentistry concepts personally from Dr. Mihir. And we have also listened to Dr. Roshan's wonderful talk about how and where the ENTs and the dental team can interact. So without further ado, I'll start with the case number one. It is something similar to what Dr. Manikandan sir was talking about. And, he beautifully described this ulcer. So this is a 38-year-old lady with a non-healing ulcer over the right maxilla for the last 8 months. May I ask Dr. Manikandan sir, can you just elaborate what other things will you look for as you were answering that question in this lady? Is there anything in specific in history that you would like to know? Anything that you would like to suggest that we examine particularly when we are encountering such a case in practice?
Yes. Yeah. Can you hear me? Yeah.
Yes, very well.
Yeah. Thank you. Thank you. It put us actually a little bit down when you say this non-diabetic. That means that we are actually looking into something which is probably one of the other things we can look into this type of infections is that whether there is actually a cause into this, whether this is actually come from odontogenic or it could be some other cause. Number one, like trauma, whether the patient had any previous surgeries or any implant placement or something like that. Some form of history is very important here when you say a non-healing. And that makes it very difficult to tell us that why this has come really, when it's specifically when it's a non-diabetic. The other thing, as I already told you, we have to rule out what is called as bone pathologies. The bone pathology, patients with bone pathologies like osteopetrosis and other major disease and other things can also get this type of. I have seen plenty of cases. I always tell my trainees when you see a bone pathology, be careful with extraction and other treatment, because after extraction you end up in having definitely osteomyelitis in bone pathologies. So look for bone pathologies. Look for other systemic involvement. When I say other systemic involvement, any other part of the body have involved with it. I have seen sometimes patients who are having also associated with axillary osteomyelitis of the femur. So other systemic involvement, specifically when you're saying a diabetic lady. And take history whether the patient had any treatment for like osteoporosis with bisphonates or whatever other things. So we have to take a good case history, which is very, very important to understand what could be the cause for this type of exposure? Thank you, Dr. Modi.
Right, sir. Right, sir. So, perfectly as suggested by Dr. Manikandan, sir, the patient had a history of fall actually 8 months back, but which was treated with just conservative management. There was some pain, intermittent foul smelling discharge, but she was ignoring it. Patient is actually a smoker. Do you see this, sir, this commonly smoking being a reason for osteomyelitis? Dr. Manikandan, sir, do you see smoking to be a reason?
Yeah, well, I have to be frank with you. I have not yet to see a single osteomyelitis exclusively associated with the smoking. But,
right, sir.
But what I can tell you is that smoking after extractions or autogenic process can always produce, I think, some audio which is getting disturbed. I don't know whose audio is it. Can we ask?
Yeah, may I request only the person asked to switch on their mics and everybody else can be on mute, please. Yeah, thank you. Yes, sir.
Sorry. So this could probably because of I have seen delayed healing. Those things are very common. That means exposure of the bone and everything. But I'm yet to see something like this purely because of the smoking. It may be a combination of everything. I'm not 100% sure whether smoking alone can produce some bone exposure like that with the infection. I'm sure there is other associated thing, like as you said, trauma, maybe not treated, exposure, secondary infection, and all those things.
Right, sir. Thank you. Thank you so much. From the ENT perspective, Dr. Dipankar, may I request your inputs if you feel so this patient along with the ulcer also had a localized edema on the face, gingiva and around the nasal vestibule. Anything else specifically, Dr. Dipankar, that you would like to look into this patient's situation? Dr. Dipankar?
Yeah.
Yeah, please tell me.
Definitely, I would go for a thorough local and loco-regional examination. The examination of the gum, the lips, and involvement of the heart palate, if any. And definitely, I will do a DNE, diagnostic nasal endoscopy, and local examination of the cheek. I will go for the palpation, and definitely I will go for radiological evaluation by CT-PNS.
Right.
Go for local care. If my diagnostic nasal endoscopy findings are clear, and if I see it is a limited disease at the level of the gingiva and at the level of the tooth, without any involvement of the maxillary sinus cavity, sinus antrum is free, then definitely I will involve my dental colleague rather than approaching on my own. And otherwise, if this patient turns up to my chamber as a first visit, definitely I will start a good antibiotic like Augmentin, local mouth care, local some gel and antioxidant, and follow up and talk with my dental colleagues.
Right.
So from my ENT point of view, I would say nasal endoscopy, diagnostic nasal endoscopy and sinus evaluation by CT is very important. Just to rule out whether the disease is how much spread it has.
Right. So, like, perfect. So, I mean, the message that perhaps that I think should go to every ENT attending and every, I would say, dental colleague attending is essentially it's all about teamwork, empirical treatment. Now, when we talk about antibiotics, Dr. Roshan, in this particular case, when faced in clinical practice, what would be your choice of antibiotics for this patient? What would you recommend starting as a first-line therapy for these patients?
Common actually to start with. So first we'll start with Amox with potassium clavulanate will be the first drug of choice, followed by clindamycin will be the choice. Okay, and when we do the culture sensitivity, see the susceptibility, the organism susceptibility, and then go ahead with the higher end of antibiotics. But to my knowledge, I always look up to my maxillofacial surgeon to look up for what type of antibiotic to be started in these kind of situations.
Right.
And but I look at the prosthetic rehabilitation very much for the patient after the surgery.
Sure.
What is going to happen?
So we'll be discussing that once we do. Now, talking about the imaging modality. Now, I just wanted to know. I mean, I see a lot of CBCT being used by our dental colleagues. Could you suggest us like what is a particular advantage that you get in a CBCT over, say, like a plain CT-PNS that we routinely order for our patients?
Yeah.
Is there like a particular advantage, or it is just that you guys are more trained to looking into CBCT and we are more trained into looking at CT-PNS?
Looking at CBCT has a particular advantage for from the dental perspective, because we will be able to look at it in a better version when it comes to the teeth boundaries.
Okay.
The teeth boundaries are much more effectively seen in a CBCT than in a CT-PNS. So we have a teeth marking called 1121, right, upper left. Okay. So the teeth boundaries make a major role in how much of maxilla we are going to cut.
Right.
What is the obturator we are going to give? What level of boundary we are going to cut on the maxilla? So this we can mimic in the negative model in our the model what we take, like a study model I was showing you, right? This. So
Yes.
in these kind of models, we'll be able to do the cut and we'll be able to mimic a obturator prior to the surgery itself, if properly planned. So the exact boundary of cut, what we are going to do, how we are going to incise, so how much level of maxilla we are going to remove, what are the teeth which we are going to preserve. So these boundaries are much more effectively seen and planned in a CBCT than in a CT-PNS.
Perfect. So not only diagnosis, surgical planning is the key. And that is why essentially, although, I mean, if a patient comes to an ENT doctor, no doubt he will get a CT-PNS done for the patient. But perhaps CBCT may also be required when you're planning a surgical management. This is similar to what Sir had shown. The patient had disease eroding the front wall of the maxilla. And the disease involving essentially just abutting the maxillary antrum and causing localized destruction, so to say. Any role for an MRI in this scenario? Dr. Manikandan, may I take your input, sir, please? Any role for an MRI, if ever, would you order an MRI for these patients? Any indications that you will look for this? Sir, your mic is on mute, sir.
I don't say no to an MRI, but then if there is an infection related to the soft tissue involvement, if we wanted to know how far it has gone into the mucosa, everything, yes. But I think if the involvement is more to do with normally a CT scan is more than sufficient for me. The issue happens, during COVID, we saw a lot of patients involving, going into the superior part to the infratemporal fossa, intracranial extension. Then, of course, a CT scan may not be only, not enough. So in such cases, yes, an MRI is necessary. But in a case where there is which is confined within the maxilla and the cygoma and everything, I think a CT scan probably would be sufficient.
Perfect.
That is my
Perfect, sir.
Yeah.
Perfect, sir. Thank you. So similar to what we do in our sinus pathologies, we would typically, for the routine sinus infections, for us a CT scan would suffice. However, if the pathology is moving out of the sinuses, it is going inside the orbit, it is going inside the brain, involving adjacent soft tissues, is where perhaps we may be tempted or required to order an MRI to look for soft tissue delineation. Otherwise, CT scan should do for the most part. Now, talking about microbiology. Yeah, talking about microbiology, sir. Now, when you do, will you be sending essentially like a culture from the site, like using a swab stick, or like you will be sending a biopsy of the tissues around, or what exactly would you be sending for culture? How would you recommend that we do a culture for these patients for deciding the right antibiotic?
Is the question to be?
Yes, sir.
Yeah.
Yes, sir.
Yeah. See, as I've already started with it, the first and foremost thing is to admit the patient, hydrate. Do the first before you do anything. Take a culture first. Whatever it is there available, you can take a scrape out of it. You can take part of the mucosa. You can take, you have to have some form of pathology or a pathogen to identify before you really start doing a treatment in these cases. So it is mandatory that we try to get one of the secretions or either a pus or a state from that area. And if possible, there's no doubt that I will send it part of it for biopsy as well. There's no doubt about it. In fact, there are a lot of microbiologists. If you can send this part of the bone itself, they can take a scrape-up of it and try to see whether there is any pathogen growing in it. So you can send it for both culture as well as biopsy together, if possible, in these type of cases. No doubt about it.
Right. So essentially, I mean, the message, what I would do perhaps is send a microbiology specimen before the first dose of that empirical antibiotic hits the system, so that
Yes.
we don't get a false negative, so to say. And any special investigations would you like to order, thinking about systemic illnesses, something like an ANA, C ANCA, P ANCA, or something. So essentially, in ENT, and perhaps this is not the most classical presentation, Dr. Dipankar, would you like to chip in terms of, I was thinking about vaginals, something that we see, although this is not a very classical presentations, but probably we see it not so commonly, but it's something that you really order for your patients.
Definitely, I would go for. Definitely, I will go for Sianca, Pianca, and ANA, just to rule out whether there is any. It is a granulomatous disease, particularly in the line of Wegener's, because it is common. We get it.
Yes, it is actually more common than we would like to acknowledge. Not something that we would see every month, every week. But this is like, this is a patient that would come us probably once in 5 years or something. So we just need to keep that antennas up when we are getting such a patient.
Right.
So
and
moving forward,
if it is in that line, the treatment protocol would be altogether different. Yes. Because we cannot, because the role of steroid comes in that case. So it is absolutely
yes. So being a systemic disease, we would like to take in more specialities in that, and being an uncommon rare presentations, possibly it would be justified to investigate that. And this patient essentially was negative. This was what the patient's intervention was done after 2 weeks of antibiotics. Once the inflammation around the tissue settled, a localized extraction was done by our maxillofacial surgeon. And essentially, I want to look at the timing. Inputs from Dr. Manikandan sir. When would you essentially think about intervening in these patients surgically? Would it be within a few days, or would you like to kind of sterilize the area a bit before taking up this patient for surgery? Early surgery versus delayed surgery, what would be your take, sir?
Well, first thing is that, as I told you, once hydrated, I do not normally like to treat anybody with uncontrolled diabetes, but there is, if possible, try to wait for the culture at least for 24 hours and see what organism is growing in there. And if there is a diabetes, there is no use in taking the patient to theater and try to do something, and you don't get any result from it. You need to get the diabetic controlled, see what is the real cause behind it, whether there is a bone pathology, whether there is a drug history like a bisphonoids, or whatever it is there, we have to get that right. Once we know there is an organism there, once we know that what is the pathology, once we 100% sure that the diabetes is controlled, I don't think we have to wait for anything.
Sure.
There is no use in waiting, because every waiting day will make it only worse. It is not going to improve in any way. In my clinical practice, I can tell you, the faster you remove the sequestrum, a dead bone, the faster the healing. There is no doubt about it.
Okay.
There is no way one can get rid of infection, either it is a bacteria or a fungus or whatever it is there. Just by doing antibiotic treatment, it is not going to help it.
Sure.
Thank you.
So, yeah. So now, more so in terms of the approach, sir, any particular technique or an approach in this particular patient that you will take, and any special tips that you would like to give to young dental surgeons out there? How would you approach, and more importantly, when you are removing a bone, is there a technique that you would like to avoid an oroantral fistula, which perhaps might happen while resecting out the bone, or you like to be as aggressive as possible and remove as much as you can?
As I already put in that during resection, there is no question of what is called as conservative management for osteomyelitis.
Sure.
Whatever the dead bone is there, it must be removed. Leaving behind this and leaving behind that, let us see what happens. Let us say one teeth. All this can only bring back osteomyelitis. Aggressive management, removal of the bone, necrotic bone, till you see a good bleeding bone. Till you see a good bleeding bone, we tend to use surgical bursts, create a lot of bleeding bone before we come out of the theater, or the surgical field is very, very important. And also very important that any necrotic mucosa must be removed. Any necrotic mucosa. And if possible, only suppose if we have sufficient palatal mucosa, sufficient buccal mucosa, which is free, without tension, you can close it over the sinus. Probably in one layer or two layer with whatever it is there. But doesn't mean that all forms of removal of maxilla will not allow you to close it. It's better that you leave it open. Come secondarily, which is smaller, later stage, you can close it. Or if not possible, you can go for a later stage, either a obturator or a free flap or whatever it is there. So I wouldn't consider closing all the after the removal. Definitely the mucosa has to be closure is not the right thinking. Thank you.
Perfect. So in an infected cavity, you would like something to drain out if at all there is a collection later, and that is why you like to keep it open. So we have discussed about the extent. Now, a quick word about post-op course, sir. How long, and I mean, like, this is just, anybody's guess, but what is your marker to know how long to continue the antibiotics and when to stop? Like, you have had a culture, you know which antibiotics, you have done the surgery, patient is healing well, patient wants to go home early, patient doesn't want to stay in the hospital. So how long would you like to continue the antibiotics minimum, and then what would be your endpoint?
Can I answer that?
Yes, sir. That's for you only, sir.
Okay. See, my take is that I do not want to discharge the patient until and unless they are clinically fit to go, including that the fever has come down, hydrated, and all these things happened. I don't think there is no reason to keep the patient. But minimum 48 hours to 72 hours of IV antibiotic is mandatory in these patients, minimum. And thereon, for bacterial infections, there is no necessity to keep the patient because you can post-operatively, you can bring these patients in the home, you can continue with it. And as I've already told you, the problem with happened with osteomyelitis always is that the blood supply. And because of this compromised blood supply, either in the maxilla or the mandible, a week or 2 weeks may not be sufficient. How do we know when to stop it? It's purely clinical examination. One is clinical examination. What is in the clinical examination? One, whether there is a mucosa healing over the whatever we left behind the bone. Number one, absence of inflammation, absence of redness, absolutely no serous or a pus discharge. All these are things which you can look into it. Once the mucosa is 100% healthy, patient have no fistula, no sinus, good healing area. Probably it may take about 3 weeks, sometimes up to 6 weeks in bacterial infections. When it comes to fungal, it is totally different. I don't know whether I'm supposed to talk about it. When it comes to fungal, like, are you coming back to that again for mucormycosis?
So we are not taking up mucus, sir. I purposefully, because we have done a lot of webinars on it actually earlier.
Okay.
So I mean, with fungus, the paradigm is totally different. We ensure a minimum dose of amphotericin and ensure how is the clinical recovery of the patient. And I mean, it's a different beast altogether.
Exactly. Yeah. That's what I'm saying. So then the whole scenario is different there. You have to probably the role of antibiotic on those cases maybe a couple of weeks. That's it. But if it is a pure fungal, the bacterial associated Staph aureus, till you see a good clinical healing, probably you have to continue minimum 3 weeks up to 6 weeks, may be mandatory. Only thing, we have to keep on checking the patient, make sure that you are not developing any resistance or a new infection anywhere else. And once we feel that the healing is done, I already told you that it is my habit. I have found excellent result in patients sending immediately after operation, at least within 10 days, for the purpose of hyperbaric oxygen therapy, along with antibiotic. And I have clinical evidence in such cases that the healing of the mucosa over this denuded bone, but all the bone we have left behind, which is a bleeding bone, is fantastic with it.
Dr. Rahul, can I add a question from the
Yes, please, Dr. Vijay. Yes, please.
Dr. Harishankar Sharma from Gangtok would like to know about any role of bone grafting here.
In the primary setting? I think in the primary setting would be not something which will be advisable in an infected base, but Dr. Manikantan can give his views.
I agree with it. Absolutely. There is no use in putting anything now because you yourself, we do not know what is going to happen to the primary surgical site, whether it's going to heal, whether it's going to, how long it is going to take it. So it is like, putting primary bone graft is something like you are going to put, a clean bone on an infected site. It is not going to stay. Definitely, I don't advise that. I always keep the option of reconstruction in the second stage.
One more question. Dr. Lourdes Albina from Chennai would like to know what's the approximate cost of hyperbaric oxygen treatment for maxillary osteomyelitis and where do you send?
A couple of centers in Chennai. You can see through the net. I don't want it to propagate through internet like this, but there are a couple of centers where they do it. But I think for one sitting, which is called as 1 hour of therapy, they charge around 3,000 to 4,000 rupees in Chennai. And you have to do at least 5 days a week. So it's something that runs about 30,000 rupees or 25 to 30,000 rupees. 90,000 rupees for 30-day sessions. So that is sometimes up to 1 lakh. But though it is controversial, I have found in my patient, it has done very, very good job in many of the patients.
It is really helpful in even skull-based osteomyelitis.
Absolutely,
yes.
Absolutely. I agree with it. I agree with it.
And sudden SNHL also we have used it, like from the ENT perspective. We have used it for a few of our sudden SNHL cases also.
Yes,
absolutely. Not responding to anything.
Absolutely, SSNHL.
Yeah. So moving forward, as we have one more case to discuss. So pathology in this space, we saw a lot of dead bone and avascular necrosis. Micro we have discussed. The special stains didn't reveal any fungus. And I mean, I would just like to take this opportunity to re-emphasize on that point that if you're not able to identify an organism and the patient otherwise clinically looks okay, please don't start patient on empirical amphotericin or empirically don't start any toxic drugs because these are drugs which need to be ideally given for long durations of time and they have their own fair share of side effects and the cost involved. So just stay away from a lot of empirical therapy, especially if the patient is improving clinically. Coming to rehabilitation, Dr. Roshan, this was a patient scenario. We have typically the interim denture scenario. What would be your approach for this patient, Dr. Roshan? Dr. Roshan, there with us? Yeah.
Able to hear me?
Yes.
Yeah. If I feel first, I look at the mucosa. If the mucosa is intact or breached before we approach for the surgery. Okay. So here in this situation, the mucosa looks intact. Okay. So we would like to remove bone and try to get a primary closure as much as possible. Okay. So the approach would be to take a model, and along with the model, we are looking at an immediate surgical obturator after the surgery. Even if after we open it up and if the mucosa we are not able to get a primary closure also, the obturator will help for the patient to get the feed properly. Okay. So that will be the right approach. So an immediate obturator immediately post surgery when you give, the healing is much more better. The inflammation is very reduced, and the primary healing is much more faster. So the immediate surgical obturator we give for about 3 weeks after the surgery. Sometimes if the cut is going to be very well planned, the immediate surgical obturator can be given immediately after the surgery is over also sometimes. Okay, so we fabricate it in such a way, or we can give it within 24 hours time after the surgery is done. Also, we can take an impression after the surgery is done immediately on table, or we can take the measurement before the surgery, do the trimming of the teeth which are involved along with the bone in the model, and do a prefab obturator which can help the patient for the feeds immediately. Okay, so this is the immediate surgical obturator, the first phase. The second phase, we try to rehabilitate the teeth also. That we start working on it after 3 to 4 weeks, which is a removable type of a denture what we give for the patient. Okay, so that will enhance the cosmetic look and for the functional aspect of chewing and eating a little bit for the patient. Then we wait for 3 to 4 months for the secondary healing to happen, and then we look at fixed options of teeth replacement along with the positioners, everything. Whether the patient, according to the budget of the patient, whether he wants a removable kind of a denture. If a removable, it will be a cast partial denture where the framework is a nickel chromium framework along with teeth, which will be a permanent solution for the patient. Or else we have to look for some implants where the bone is going to be completely lost, the alveolar bone is going to be completely lost. We have to look at options of, if the patient is looking for a fixed prosthesis, we have to look at the option of, if the zygomatic bone is good, we have to look at the option of zygomatic bone implant placement followed by the teeth replacement with the support of the zygomatic implant. That's the phase 3. The phase 1 is the immediate surgical obturator. The phase 2 is an interim obturator with a fixed set of a removable denture kind of thing with the teeth for about 3 months, wait for the secondary healing to happen. And then after 3 months, we plan for fixed replacements for the patient.
Perfect. Would your approach change if there is a frank oroantral fistula there?
Yeah, if the oroantral fistula is there, the approach towards the type of process what we are going to do will be changing. Okay, that case to case it differs. Okay, subjective to the depth of the defect. How much is the defect? Okay, how we are going to close it. What is the teeth which is left out, which can hold on to the prosthesis? So all those things, case to case basis, will be changing over. And what is the patient's expectation? What type of expectations he is having? What is the cost pattern? What is looking at the budget of the replacement? Everything we have to collate all those things and then come to a conclusion of what possible solution can be given for that particular patient to meet the particular need. But ideally, oroantral fistula closure, a simple oroantral fistula can be closed with a good obturator if there is partially some set of teeth left out.
Right. So, permanent rehabilitation, like you said, for the zygomatic implants. Moving forward, would you like to explain this, the lab work to us, Dr. Roshan, the ones that you had shared with me?
Yeah. So actually, this is a pre-op model we have taken for a patient who have come with the maxillary osteomyelitis. Okay. This was related to COVID only. Okay. But we are not going to discuss anything pathology related part of it. Okay. So this is the first model and the second model. Okay. Upper jaw, the pre-op model. Okay. So we take a CBCT, take the boundaries and how much we are going to cut. So what we can do is we can trim the teeth in the model itself. This is a negative replica of the upper jaw. You get it, Rahul?
Yes. Very well.
In this, we kind of trim the teeth and make an obturator ready before the surgery is being planned. Okay. In the surgery, if there is an extra kind of two teeth, the boundaries are going to increase. We add on a little bit of acrylic in that region and make the obturator, adjust the obturator, and we can fix it 24 or 48 hours after the surgery for the patient.
Perfect.
Suppose there is going to be a slight kind of mismatch. What boundaries we plan, it's not going to happen exactly the mirror image. So we can add on or reduce this obturator. This can be trimmed. Okay. The patient is going to wear for the next 3 weeks till the healing is going to happen, and maybe a little bit of betadine gel which can be put on the inner aspect of the obturator, which will help to keep the tissue disinfected, also will be helping the patient, and for better healing. Okay. The gel what we suggest is betadine gel, or there is my special recommendation will be a chlorhexidine gel, mucane gel, hexi gel what we call it as. That is a very good gel. It's an antibacterial for all kind of small oral infections. Chlorhexidine is considered the gold standard for us actually. So this the patient wears for the next 3 weeks. The primary healing is happening, or wait for another 1 week. Then the patient comes back to us, take a nice impression, get a proper obturator done along with teeth for him, so that the primary essential need of a cosmetic thing and a little bit of speech, the nasal twang is improved for him, and a little bit of chewing to happen. These kind of dentures are removable dentures, which he can wear for the next 3 months to move out for him, so that he doesn't have any major problem of the primary problem is solved. If there is a fistula, the fistula is closed for him. Okay. And his smile line is improved and he's able to chew a little bit. These dentures may not be able to give you good amount of functional load. Okay. So this he can wear for the next 3 months. The next we have to look at the it's a processes, proper processes. Okay. So here in this patient, he had a small fistula here. Okay. So this was managed with these kind of dentures. And then we look at the problem of there is no alveolar bone for placement of implants. So then we look at the zygoma. How is the zygoma? Then again we take records, photographs, models, CBCT, everything. And then we try to, what we do is, we try to make some markers here in the dentures. Like you see these yellow spots here in this denture. We put some Gattaparka points, which we use for root canal filling. Those are being incorporated, imbibed into this denture. And this denture is also made a CBCT. And the jaw is also had a CBCT done. Then we superimpose this denture and the jaw together. Perfect. And try to get the orientation for the implant in the software. Once this planning is done, then we go into the surgery and place the implant with a position in which that this denture can be withdrawn inside. When we remove this denture, there is a metal framework which can completely hold on to this denture. This is an over denture what we have planned. Okay. Yes. Since the fistula is there, we have planned over denture because it acts as an obturator, as well as it's a good solid seat is there. So there is no rocking. It's very almost like a fixed. There is a titanium bar inside below this denture, which is completely fixed with the implant, and then on top of it, this denture is placed.
So that play the video. We'll be able to see that very clearly in the video. I'll just play that video that you had shared for the patient. So you may describe the video, sir.
Yeah. So what I was talking to you, pre-op, this is a OPG for the patient, and we are confirmed, and after the maxillectomy is done, you can see a little bit of fistula there, and this is the interim obturator which has been placed for the patient. And then we plan for the surgery with this interim obturator, and then here we have done the zygomatic implant and one more implant which is placed for the other side hole. At that time we removed another tooth also. That implant is an alveolar bone placed implant, and on top of it you have a titanium bar which has been there. Still you see the fistula here, and there you close it with a complete fixed obturator. This is a semi-fixed obturator. Okay, this can be removed at any given point of time by the patient, but this titanium bar is not it's completely fixed. It cannot be removed by the patient.
Okay, perfect. So now coming to the take-home point, and the biggest take-home point for me is essentially collaborate and communication. There is a lot that I learn every time that I interact with my dental colleagues, and there's a lot that we can do to improve patient health care. Quickly moving on to our second case in the interest of time. This is a
one
patient.
Question, Modi.
Yeah. Go ahead, Dr. Vijay, please. Dr. Vijay, you're on mute.
Can you hear?
Yeah, we can hear now.
Related to that same Gataparcha, Dr. Abhina, she is asking, will you use Gataparcha following maxillectomy in infective cases?
No, we will not use that. This is just to, Gataparka is an inert material which we use for root canals. So those kind of material is just incorporated into the denture for like a marker for the landmark of the denture to be placed on top of the area where the rehabilitation is going to be done. So it's not, it's a tool which is primarily used for root canals, which we try to accommodate it for another use of like a marker for it.
Right. Can we go ahead, Dr. Vijay? Any more questions from your side?
Here, there is a lot of multidisciplinary work which happens. Actually, I want to add on to that. There is a separate team of people who do the implant planning, and again, maxillofacial surgeon. Then myself, with the prosthodontist, everybody together, we work on and we get this job done. So there are 3-4 people involved in this. Subdental specialties which are involved in this actually.
Right. So moving ahead to our case number 2, this was a 8-year-old male child who presented to the dentist. The dentist is there with us on the panel right now, Dr. Mihir, and he presented with malaligned teeth to him. The child had a bilateral crossbite at presentation and a high arch palate, which is what perhaps prompted him to send him for an ENT evaluation. So, Dr. Mihir, for the benefit of the ENT audience out there, and also for your dental colleague, which are the particular malocclusions which you think need an ENT evaluation? Which are all malocclusions would you send for an ENT evaluation, or are there specific malocclusions that you feel have a higher propensity to have an airway obstruction as the cause for the malocclusion? Which are the ones that would trigger an alarm bell for you and you would refer them?
So as the research is growing, it is shown that many of the malocclusions are now having some ENT connection, especially when the adenoids or tonsils are inflamed. And the majority of the open bite and the cross bites, they usually tend to have a enlarged adenoids or tonsils. So majority of the cross bites with the narrow maxilla or even the mandible, retruded mandible, like a class 2 malocclusion, with Dr. Rochin have shown in a few of his cases, they tend to have some amount of tonsil or adenoid enlargement. Even in many cases, there is nasal polyps, which is also leading to the mouth breathing habit, which is increasing the problem. So although often that is missed by a dentist in their x-rays, so even if the child is having, say, the lateral cephalogram showing no signs of any obstruction, it is still important that they get their airway evaluated by an ENT in order to see whether is there any obstruction in the nose, because it's not possible for a dentist to evaluate the nose. So majority of the cases where when we see any malocclusion, we tend to ask the history for repeated cold and cough infection, mouth breathing, snoring. Many of the kids are having teeth grinding or bruxism. Often they are having bedwetting. Even restlessness and ADHD is nowadays linked to airway issues. So we ask this history, and we suspect that the child is having some amount of airway dysfunction going on. We refer them to their ENT physician in order to get their ENT airway evaluated completely.
Right. So, Dr. Dipankar, the patient has come to you. Your dental colleague, your pediatric dental colleague has sent to you. What are essentially the symptoms that you would specifically look for in terms of evaluating these childs for, an obstructed airway, perhaps a sleep disordered breathing, oblique OSA? Is there anything specific that you look for?
Definitely. Particularly for the most important thing is, apart from the common symptoms of sleep-related breathing disorders, which is common for both adults and pediatrics, like snoring, mouth breathing, disturbed sleep, multiple arousals. The daytime sleepiness, what we usually get for adults, usually for the pediatric, it is just the contrary. It is just the opposite. Instead of daytime drowsiness and sleepiness, underactivity for the adults, for the pediatric SDB patients, they are actually hyperactive. They are irritable, hyperactive, some kind of ADHD-like of symptoms, poor concentration, memory loss, and poor performance in academics, particularly science and maths. These are the symptoms I specifically ask. Apart from the routine symptoms like bedwetting, choking, and early morning headache, these are the dry mouth. These are routine symptoms, but particularly I evaluate from the symptoms. If you want to know the symptoms for this current question, would I limit my answer to the symptoms or findings also?
Just the symptoms now, sir. We'll come to the science soon.
Yes. Then
Yeah.
this. Then particularly this. The take-home message, a very important message from my side. Instead of underactivity and daytime sleepiness, for the pediatric patients, they are usually overactive, hyperactive.
Overactive. Yes.
So
Yes.
overactive
Yes.
and extremely irritable, and many times they are attention deficit hyperactivity disorder kind of symptoms.
Right. So there is a small system that we have developed. I mean, I get to work very closely with a very busy and a very senior pediatric dentist here in Mumbai, and I've got to learn a lot from her, Dr. Meenakshi Khair, and we do a lot of back and forth with our patients. So she has developed her own like a screening tool where essentially it's just like on this small piece of paper, she will do a quick screening of any and every kid that she suspects, with any malocclusion, with any signs of airway obstructions. She'll quickly do a screening of all these symptoms, and it does two things. It helps us kind of like evaluate the severity of the symptoms, develops a checklist. Also, it essentially creates an awareness within the parent that this is more than just a teeth issue. It is, and the parents are a little more motivated because a lot of these patients may not have the classical recurrent cough and cold symptoms. So they are like, why do we need to go to an ENT now? And why do we need to get it evaluated? And she's like, this is what the screening tool shows. So it's a great way to communicate. She will just take a snap of what she is, you see this tiny notes that she has made, and then she'll just send it across to me over WhatsApp. So I know exactly when the patient comes to follow up, I don't have to spend like an hour discussing just symptoms. I need to know where to focus. I'll quickly go over the symptoms, and then we can get on to the evaluation. So works like an excellent communication tool between, say, two specialties, and I get to learn a lot. Like, looking at these tools, and it forms a good basis of communication, even a good research tool perhaps to look at what areas improved after whatever interventions that we have done. It's a good way to document these symptoms. Now coming to the science, Dr. Dipankar, what is exactly that you look for when you look at a child for sleep apnea in terms of an examination point of view, strictly?
Yeah, first of all, the facies.
Yes. I think Dr. Dipankar's video or the Zoom link has paused. Dr. Vijay, would you like to contribute in terms of what else can one look for in a patient with SDB from the ENT perspective in terms of examination of the upper airway?
The high arched palate, narrow maxilla, the width of the maxilla, the width of the hard plate, very narrow in these patients. And there are different kinds of permutation kind of combination kind of dental malocclusions like overjet, overbite, crossbite, and definitely related macroglossia. So these are the findings what usually we routinely get. And apart from that, overall the BMI, I don't basically neglect the anthropometric issues. The skinny babies often we get, the chubby obese babies. So, and very important, the discussion what you are telling, the discussion with the parents are all that is very important. Exactly what is their expectation, exactly what is the purpose of their coming down to us. If they come down to us, then it is extremely important to make them understand that just by removing these big tonsils and adenoids may not help us reaching our end point. So then we also refer myself personally, just like you and Dr. Roshan, what you are telling. I also send my patients to my dental colleague, cross-evaluate, make my parents understand what is the importance of this. Is not any cosmetic issue. This is from the long-term point of view. So ENT and dental simultaneous concurrent evaluation is all that is important.
Perfect. So one thing that I would like to stress to my ENT colleagues is traditionally we are trained to look at the septum, we are trained to look at the turbinates, but we sometimes forget to look at the nasal floor. A lot of times the obstruction comes from a very narrow nasal floor, which is essentially an outcome of a very high arched palate. And you may struggle even in adults in these patients to even introduce scopes inside. Whereas the problem is not with the turbinates, the problem is not with the septum, the problem is essentially the denominator. The floor essentially is so narrow that the patient is perhaps having these symptoms, and that is why treating the maxilla is very important and not just treating the nasal cavity in these patients. Going forward to our patients, we have had a small discussion on when we do a CBCT, when we do a CT scan and an X-ray. For this patient, we did an X-ray. And what we found was an enlarged adenoids. First line management, essentially, Dr. Vijay, would you like to tell us what would be your first line management in these patients if you're around? Dr. Vijay? Yeah, Dr. Dipankar, can you tell us, I think he's off for a bit. Can you just tell us what would be the first line management for these kids?
If there is such a significant adenoid, then definitely after proper counseling, I would go for adenoidectomy. But having said that, very important is I have to tell my basically kids' parents exactly what is our purpose. What is our purpose of doing the adenoidectomy? Just to clear the posterior nasal airway, or we are wanting to give a overall holistic management from sleep disorder point of view. If we are actually treating a pediatric SDB, then just by eliminating the adenoid may not help us reaching the endpoint. So what you were just now told, looking at the nasal floor and maybe in the long run expanding the hard palate, that is the rapid maxillary expansion. If he is within the ossification, before closer of the ossification age.
Dr. Dipankar, we'll touch that just from the ENT perspective now. Just in interest of time, because we are running short of time. I mean, interesting discussion. So, question to you: would you do an adenoidectomy in a patient with frank signs of SDB, or would you do an adenotonsillectomy? Especially, see, the decision making is easy when the tonsils are large, grade 4 kissing tonsils. No, I mean, we have to do an adenotonsil, but it's like a grade 2 tonsil. Patient is having frank signs of SDB. Would you do a frank adenoidectomy alone, or would you do an adenotonsillectomy for these kids? The patient is in front of you.
I will go for adenoid and tonsil both. Perfect. I will go for adenoid and tonsil both, because we know many a times there are endophytic tonsils, and particularly the upper pole of the tonsils, which is pressing upon the airway. So just by looking at the tonsil, even if it is not look like a grade 3 or 4, if I am treating an SDB, I will go for tonsil and adenoid both simultaneously.
So the perfect message for all the ENT colleagues out there too. Although adenoidectomy is perhaps responsible for 70-80% of the obstruction and the tonsils may not appear large, if you are finding signs for SDB, go for a complete adenotonsillectomy. You want to create as much space as you can with minimal morbidity. That is the end point. That is what you want to achieve. And there are studies to show that a lot of these kids may have a compensatory, perhaps, enlargement of tonsils 6 to 8 months down the line. And that may create a problem in the future, may not give us an optimal outcome when we are looking at the endpoint later on. So go for a complete surgery, unless and until there is some systemic issue and you're dealing with a special child and it's too much of a trouble, because tonsillectomy does add to the pain and the post-operative care becomes slightly more difficult compared to a plain adenoidectomy. But essentially, for all your SDBs or suspected SDBs, please go for an adenotonsillectomy, even in a grade 1 tonsil situation. Now, exactly. Indications for a sleep study in these patients. When would you do a sleep study for these patients? Do you order a sleep study for pediatric patients, strictly for pediatrics, and say? Dr. Dipankar, please.
Yeah. I will go for polysomnography for pediatric patients if there is persistent sleep disorder, persistent OSA even after tonsil and adenoid. That means already tonsillectomy and adenoidectomy has been done, and the child is still suffering from sleep disorder breathing. PSG was not done at the first set. Already tonsil adenoid removed. Now I am dealing with a persistent sleep apnea even after TAR. I will do PSG. Number two, definitely I will go for syndromic babies. Number three, if there is any muscle tone disorder like mucopolysaccharidosis or Downs or this kind of special syndromic babies, I will go for PSG, pediatric PSG, routinely. And particularly for thorough evaluation, definitely though the level 1 study is the classical gold standard, but for practical point of view, often I go for level 3 HST.
So what is the youngest child for which you have done a level 3 study, Dr. Dipankar?
8 years.
8 years. So the challenge comes now, if you get a child, who's like 4 years, 5 years, you get a lot of these syndromic babies with Prader-Willi syndrome, where, the endocrinologist wants to start, the pediatric endocrinologist wants to start their growth hormone therapy, and which essentially is known to worsen SDB in kids. So that comes a challenge, right? So, I mean, so there are guidelines out there. There's a very nice paper by the American Academy of the ENT, which recommended essentially what Dr. Dipankar just said, that one must try and do a PhD for patients with systematic issues, with mucopolysaccharidosis, with obesity, with Down syndrome, if it is not a classical case. And also, essentially, one should try and do an SDB where we see a problem where we are uncertain whether there is, SDB symptoms or not when we are in doubt, or there is a discordance between the size of the tonsil on physical examination and the reported severity of SDB. So where we want to make a decision. However, PhD is not the end of all. It is difficult to get it done. A level 1 sleep studies, even in metro cities, I would suggest it is expensive, time consuming, and more importantly, in a lot of patients, it will have limited prognostic value. I mean, if the symptoms are there, even if the PhD is, so to say, within the realm of normal, we would be a little more aggressive in treating children, little more proactive is what I would say, than, let the child suffer, especially if conservative managements like use of nasal sprays and all are not helping. Now, moving forward, we have done the surgery, TNA is done. Talking about, now improving, if we have improved the form, talking about improving the function. So, Dr. Mihir, question to you. Can you just explain this? What is exactly the procedure done for these children for the interest of our ENT colleagues? What is the endpoint and what all procedures can be done for these kids? Dr. Mihir?
So usually we follow a 4-step rule or something, that any child who's having a dental malocclusion along with any airway dysfunction like SDB, the first they have to be evaluated completely by an ENT physician. This is followed by the lateral cephalogram analysis, that the X-ray that.
So, Dr. Mihir, sorry to cut you short. We are running short of time. Just post-operative, the child has underwent surgery.
Yeah. So this child, we had given him a rapid palatal expansion. So we increased the width of the upper jaw from around 32 millimeter to we have reached to around 37 millimeter. So that has also helped to increase the floor of the nose. And that has helped in the breathing. It has helped in the volumetric changes. And this was followed by myofunctional therapy and exercises, which helps us to has helped to restore nasal breathing and establish a tongue tone and the correct tongue posture to keep the tongue on the roof of the mouth. So after creating space for the tongue with the help of rapid maxillary expansion, it is very important that the child, the function is restored. The function is restored by the correct nasal breathing. So good breathing exercises are prescribed to the patient, along with some tongue exercises and muscle exercises to improve the tone of orofacial muscles, which comes under orofacial myotherapy. So that is done for the patient.
Yeah. So we'll discuss myotherapy. Dr. Roshan, quick question to you. These are the 3 modalities that I'm aware about that we have in our hand. We have the RPE or the RNE. the myobrace, and orthodontic. Now, which patient needs what? Do you do everything for all your patients? How do you separate? Dr. Roshan, if you're there.
It's a very, very subjective to patient wise, we need to plan accordingly. So,
so if you
as a core clinician, core clinician, what we think is we need to give results for the patient. Myobrace is a removable appliance. We require the patient's compliance. So in those situations, most probably the best results are happening only with maxillary expansions, the RMEs. Okay. This is a stage 1 where we correct the cause. The stage 2 is orthodontic treatment, where we correct the effect of the problem, the alignment of the teeth and all those things. Okay. In between, add-on of myotherapeutic exercises will help the patient because the brain is programmed to swallow in such a pattern for the past 8 years or 9 years. Okay. So to reprogram the brain, the software, the hardware is made perfect. That's the maxilla. So the tongue swallowing pattern has to be improved. That myofunction therapeutic exercises will help you to get it in order. That's the only thing. Yeah.
Now, quick questions. Lower age and upper age limits for RME. What is the youngest kid and what is the oldest kid or the oldest individual that you will do an RME for? And
youngest age group I have done is 4.5 to 5 years I have done, the youngest. Yeah, the oldest I have done is till 14-15 years we can do because the maxillary mid-palatine suture completely fuses by 15 once the post-puberty. Okay. After that, if you are planning to do, you have to do a cut. That's called a surgically assisted rapid palatal expansion. That's called SARPE, S-A-R-P-E. It's called surgically assisted rapid palatal. It's a surgical procedure where we induce a cut on the mid-palatine suture and then do the expansion. That's how we do it.
How do you judge that the palatine suture is fused? So is there like a clinical judgment just by age, or is it something?
Your hand wrist radiograph can give you the exact judgment. Your the fusion of the cartilage here, right? What we call it as this will help you to know that that's the 4th stage of closure. Okay, a finger, the finger hand wrist radiograph in the finger, the phalanges fusion will help us to know whether 80 to 90% of the growth has happened or not.
Perfect. Any opinions on dome? Have you heard about dome, distraction, osteogenesis, and maxillary expansion?
Yeah, maxillary expansion itself is a form of distraction osteogenesis only.
Right.
Okay.
So there is a procedure called as a dome where essentially along with, I think it's more of an advanced surgically
that is
assisted
more
RME.
of a syndromic cases where you have a hemifacial microsomia or a severe retrognathia or a genetic malformation. As such, in that the bone is formed very small. Retrognathia, in those kind of situations, dome is much more helpful. Okay, where it's surgically placed inside the patient's mouth and then the activation is done after that.
Perfect. Dr. Mihir, words about myotherapy. Quickly, your goals and the schedule and the time duration that you do for these kids.
Yeah, so after we have created the space and created the form for the correct breathing, it is also important to restore the function and at the same time increase the tonicity of the oropharyngeal muscles. So often these hypotonic muscles is one of the reason why the airway collapses in spite of clearing the airway. So it is important to improve the tonicity. In order to improve the tonicity, there are some oropharyngeal exercises and breathing exercises. So here you can see some of the exercises which helps to improve the tone of the upper lips and the tongue. So one of the child on the right, you can see the child is holding a button and she's pulling the button with the help of only their lips. So this exercise helps to improve the lip tonicity so their lips stays closed. So it has been shown by Guillemot that establishment of the nasal breathing is very important after all the intervention is completed. So for that, the mouth should stay closed. And most of these kids have a hypotonic upper lip. Their upper lip are very hypotonic. So this exercise improves the tonicity, and the exercises of the tongue helps to keep their tongue on the palate, which is the resting posture of the tongue. Majority of the kids with SDB have a low tongue posture and they tend to block the airway while sleeping, which leads to SDB. So improved tonicity of the tongue helps to get the correct tongue posture. So it's like a physiotherapy after any orthopedic operation or any bone operation we do. Similarly, myotherapy is like exercises for the oropharyngeal muscles after any ENT intervention we do.
Perfect. Duration, typical duration, how long do you recommend?
So it usually continues for around 2 to 4 months. We prescribe exercises, one set of exercises for every 15 days. And this includes nasal breathing exercise, tongue exercise, lip exercises. In some cases, we often give some habit correction devices like vestibular screen or MyoBrace along with it. And we call them every 15 days, which continues for over a period for 2 to 4 months, depending upon the severity of the problem.
Perfect. And long-term follow-ups and relapses, like failure of therapy, like 2 years down the line, 3 years down the line.
Failure majority occurs because if there are any compliance issues, because it's difficult to get compliance from children. But as you make them aware, so we have to make this feel a little bit interesting. It has to be done in a proper pediatric setup, and we have to make the exercise lucrative for kids so that they enjoy doing these exercises. And so if these they find it interesting and the parents are motivated well, then the compliance rates are good. So the success of getting correction with the help of these exercises is dependent on the compliance. So that has to be done in a very child-friendly way. So if it's done in a child-friendly way, we do get a good compliance and a very good success rate. Even the articles by Camacho from Stanford University, the latest systematic review on myofunctional therapy has shown that just with the help of MFT, the myofunctional therapy, the AHI index is reduced by 50% in adults and around 60% in children.
Perfect. So coming to the paper by our beloved and the most revered Dr. Guilleminault, very clear message, 2013 paper. They took up 24 kids who had a normal PSG after an adenotonsillectomy. So a successful surgery. However, as they followed up these kids between 22nd months to 50th month after surgery, so fairly long follow-up, 2 years to 4 years, 13 out of 24 kids who did not receive myofunctional therapy after a very successful surgery developed recurrence of symptoms. Only 11 who followed up with myofunctional therapy were able to maintain their success for at least 2 years after results. So a message to all my ENT colleagues, after a TNA, you need to send these patients, all the patients, to the pediatric dentist for their evaluation, especially if the kids are beyond the age of 6 to 8 years, because they will have some component of poor muscle tone. The younger that you operate, perhaps that much habits may not have, but it's a good idea to get every kid screened. I do a screening for all the kids that I operate, once pre-operatively and once post-operatively, compulsorily by a pediatric dentist. Coming to the topic of tongue ties. So traditionally for ENTs, tongue tie has always been a language issue. If the kid is able to pronounce the vowels, the consonants, the babas and the lalas, we say that tongue ties are fine. Is that true, Dr. Roshan? Any opinion on tongue ties? The role that we should do?
Sometimes what happens is, apart from the speech issue, the tongue tie also impedes the growth of the jaw. Okay, so it's all the equilibrium is kind of disturbed. If the tongue tie is causing some kind of issue in the development of the jaw, also apart from the speech, then also tongue tie we need to intervene. Otherwise, what happens sometimes, you see a very severe tongue tie, but the child is the development is good and speech issues are kind of good, then we don't kind of intervene. So it's all a case-to-case basis. We need to analyze and we need to do the tongue tie.
Perfect. So when faced with a tongue tie, apart from speech issues, for ENT colleagues, please look for jaw development also. If you feel the jaw development is suboptimal, when in doubt, ask a colleague. Tongue ties are not to be ignored if the speech is all right alone. Please look for jaw development. That's a message. And again, a very classical paper by none other than CG himself, that a short lingual frenulum left untreated at birth is associated with obstructive sleep apnea syndrome at a later stage. Why is that? Because these guys may develop a deficient maxilla. These guys may develop a deficient upper airway, which is structurally deficit, skeletally deficit, because the tongue tie was not released and addressed at the age where the skeleton was, so to say, moldable. So please don't ignore tongue tie. Please address them from the jaw development issue also. Dr. Mihir, thumb sucking and OSA, your thought process.
So majority of the kids who are thumb sucking, they tend to have a proclined maxillary teeth and a narrow palate, and they often present with a posterior crossbite. So because they have a posterior crossbite, so they tend to have airway issues as well. So it has to be intervened as early as 2 to 3 years of age. So initially some psychological counseling and those things are prescribed. If it is not corrected with the help of counseling, then we have to give some habit correction devices like cribs in order to prevent thumb sucking. But it has to be stopped early as possible in order to prevent the jaw growth issues.
Right. So just a quick recap for the image that I've shown here. This is the kid with a normal airway, with a normal mouth closure and breathing through the nose. This is ideal. Now, a kid with a low tongue posture tends to be a mouth breather, with a poor tongue tone tends to be a mouth breather. So when the kid sleeps, so this is the kid when the kid is awake, when the kid goes off to sleep, the tongue essentially falls back and causes an obstruction. How does the kid ensure that the tongue is not following? What is the oral appliance that the kid uses? It's the thumb. So the kid is essentially using the tongue to, essentially the tongue is getting pulled forward by the suction mechanism when he's sleeping, and that the thumb is used to open up this passage. So if a kid is presenting with thumb sucking and it is difficult to take the kid off that habit and persistent issues are there, keep an eye out for an obstructed upper airway, and treating the airway may help in quitting that habit. Pretty new area of research, very little published high quality, I would say, studies out there, but a developing area where, again, scope for collaboration between the pediatric dentist and the ENT colleague exists. So thumb sucking and OSA, please keep this eye open and look for it. Last but not the least, very important article again by Christian Guilleminault, the father of sleep medicine. And the conclusion is very clear. Pediatric OSA in a non-obese child is a disorder of orofacial growth. So if you get a child with suspected OSA, you do a tonsil and adenoid, don't think the story is over. Please ensure that the child is back to having a normal functioning jaw development, which is as close to normal as possible. So quickly, take-home points. While treating open bites, mouth breathing and malocclusions, one must focus on treating the reason behind the maldevelopment. A message for our pediatric dentists out there. Screening for SDB symptoms is important in kids with mouth breathings, with tongue ties, with thumb sucking. A pediatric dental consult is advisable for every kid undergoing an adenotonsillectomy. A strong statement, I know that, but I'll tell you, once you start looking for these things, there are symptoms like grinding of teeth, magically disappears once you treat them well. There are symptoms, not only snoring. So there is a lot of correlation happening out there. And if you don't treat this, relapse rates are very high. And early intervention with follow-up myotherapy can effectively neutralize any abnormal orofacial development. So with that, I would like to thank you and thank the panelists for being so wonderful and making their replies short and crisp. Back to you, Dr. Vijay sir. Thank you so much again.
On behalf of IAOHNS, I would like to place my sincere thanks to this entire spectrum of faculty who has joined for this live webinar discussion on this Sunday evening. And also would like to thank the participants who are nearly 750 across India and few from Middle East and UK who really encourage us to conduct more programs. I'm sure this topic can be discussed for a whole day, and our moderator, Dr. Rahul Modi, has clearly got out the most possible and strong, important evidence-based messages on this interdisciplinary management topic from all the faculty who are key leaders in this field. So I would like to thank GSK, especially Mr. Keshav Shankar and their entire team who are working behind this program to help spreading the knowledge, which is the main aim of our Indian Academy. Those who are not members of IAOHNS, I would like to welcome all to be part of IAOHNS by becoming a member. You can download the membership form from the website www.iaohns.com and send it to us. And the next program is going to be in the month of June, second weekend, with a different interesting topic. And I would like to thank the participants and also to visit iaohns.com and iaohnswebinar.org for the update. Thank you all. Thank you.
Thank you. Thank you. Thank you.
Thank you.
Have a good day.